Thank you so much for having me. I'm really glad to see you guys come out tonight. I first wanted to ask, anybody been to Seattle in the audience? Can you raise your hand? Wow, quite a few of you. Great. We just had the snowstorm of a lifetime. I don't know if you heard about that on the news, but it was crazy. We got 20 inches where I lived, and that's just unheard of in our area. So maybe up in the mountains, but not down towards the Sound. So it was lovely for me to be able to come down here and get a little bit of your sunshine, and I'm enjoying it, so thanks a lot. So what we'll talk a little bit about today, I want to talk a little bit about the history of medical cannabis use. Does it work, and if so, for what might it work in terms of mostly symptom management? I want to talk a little bit about the forms of use and the pros and cons of how one might use the product. And also any reasons perhaps to not use it or consider not using it, and adverse effects. And we might talk a little bit too about dosing, because a lot of people have questions around that. So the first thing I want to say is that cannabis has been called many different names and a lot of different things. It's been glorified, it's been vilified, but it's just a simple plant from the Cannabaceae family, which also happens to include hops, which I think we're all familiar with. So in essence, those two are cousins. And a really quick history tour of cannabis. Cannabis has been used for centuries for a fiber as a foodstuff in terms of the seeds of hemp. And we have evidence that cannabis has been in medicinal use since before written history even. And the earliest written history that we found is in Egyptian medical writings over 3,500 years ago. And in 1st to 2nd century China, somewhere in there, their very first compendium of medicines included cannabis as a medicine and how it might be useful. And it was introduced to modern Western medicine in the early 1840s when a physician who'd been doing some work in India and had discovered it there found that he could palliate the terminal symptoms of rabies in a patient, which they didn't have a lot to really help with at that time. It ended up in the U.S. Compendium of Medicines, and right around 1937, the United States levied a huge tax on cannabis, which made it essentially unaffordable and unattainable for people. And so around 1942, it was removed from the U.S. Compendium of Medicines, which is called our U.S. Pharmacopoeia. And then in 1970, we created the schedule classifications for drugs, and it landed in the Schedule I classification alongside of drugs like heroin and LSD because it was considered to be high risk for abuse with no accepted medical use. So today, we've kind of got what I would call a green tide going on. And you see in those very darkest green states, the olive color, of which there are 10, those are states that have both recreational and medical use. And overall, we have 33 states, including those 10, and that would be the next darkest color of green, that have medical cannabis laws on the book that would be considered comprehensive. So a comprehensive medical law is one that allows for both THC and CBD, or the whole plant, in some way. Then you see those lighter green states where basically they allow for the use of CBD, one component of the cannabis plant, provided that the THC, which happens to be a psychoactive component of the plant, is in very low concentration. And we'll talk a little bit more about that in a moment. And as yet, we still have 4 U.S. states that don't have any form of medical cannabis access on in their law books. So just to give you a little bit of an understanding of what I would call our endocannabinoid system, and I like to say our because I want it to be really clear. This is a system that exists in our bodies. It is a set of receptors. 2 of the most commonly known are CB1 and CB2 receptors, one of which is found primarily in the nervous system and the other in peripheral cells and in the immune system. And then endocannabinoids, which are actual chemical things produced in our body that interact with these receptors. And the first endocannabinoid that was discovered here, the anandamide, ananda is actually Sanskrit for bliss. So it was named as the bliss molecule. And then enzymes, which actually bring these molecules into being and then degrade them when the body is done using them. So what's so special about cannabis is that it contains something that has been termed phytocannabinoids. Phyto is Latin for plant, so basically what that means is that there are chemicals in plants like cannabis, and I think primarily they've only been found in cannabis so far, that interact with our receptors, our cannabinoid receptors, or who have very similar chemical activity or chemical similarity, I should say, with the cannabinoids that we produce, or both of those characteristics. And there's over 110 cannabinoids in cannabis that have similar chemical characteristics and may exert activities on our cannabinoid receptors. Some of those properties include pain relief, anxiety relief, anti-seizure properties, anti-nausea, anti-inflammatory, antioxidant, anti-tumor, and protective of the neural system. So this is designed to just give you an idea. I know it's really busy, so don't get too caught up in it. But this is designed to give you an idea of there being some differences in the cannabinoids depending on in what form we're getting them. So in the raw plant, we have what are termed cannabinoid acids. So the A here behind each one of these abbreviations refers to an acid version of the cannabinoid. And when these things get heated, which is typically how we end up ingesting them, we either heat them in some way before we use them or as we're using them, then you see that these particular acid parts of the cannabinoids become minus the acid. So you go from THC acid to THC, and you have some additional properties associated with that. So I don't have it up there so you can actually read them, just wanting you to see that there's quite a lot of different properties associated depending on whether something in the cannabis is consumed raw versus heated, or if the cannabinoids are aged, then they can often turn into other types of cannabinoids with their own individual properties. So the most studied cannabinoids that we know the most about at this time are THC and CBD. And THC interacts very strongly with one of the receptors in the nervous system, the CB1 receptor, and very weakly with the immune cells. And the major effects we know about it are, of course, the psychoactive effects, the anti-nausea, possible pain relief, antispasms, and anti-inflammatory effects. And what you see on the right-hand side there are the associated drugs, prescription drugs, Marinol or Dronabinol, Sesamet, or Nabilone. These drugs are synthetics typically. They're synthetic versions of THC. Sativex or Sativex, people call this a little bit either way. They call it that name. Nabiximols would be the generic name for that. Is actually a combination, as you can see, of THC and CBD. And then the drug levonorgestrel is an injectable form of the drug that's only been used in research. CBD interacts with very weakly, actually, with these two primary receptors. It does appear to have a role in pain relief, neuroprotection, anti-seizure activity, for which actually we have a new drug for some very specific pediatric seizure syndromes called Epidiolex, which is a pure cannabidiol or CBD product. It can also reduce anxiety, and there is some evidence that it may be helpful with nausea. So there's some other good stuff in cannabis that is also found actually in other types of plants that we might use. And they're the terpenoids. And these are essential oil components that some people would say give it the characteristic aroma that it has, and some people would even say the characteristic flavor. And they do have some pharmacological effects in the body. And so some of these include limonene, myrcene, pinene, linalool. There's a couple of different caryophyllines, nerolidol, and phytol. And all of these are found in other types of plants, some of which we might actually eat or use in some way. So I've called out here that, of course, the little lemon down there at the bottom, limonene is something that's found in the rind of a lemon, and we tend to use that in cooking and enjoy that. Myrcene is a terpenoid that you also would find in hops, and it gives it a characteristic, the hops a characteristic smell and flavor. Another example would be pinene, which we use pine derivatives for cleaning, and I think we probably like the smell of that. It smells fresh and clean when we use pine sol, right? Linalool is something that's found in lavender. And of course, some of us like to use lavender for an aromatherapy for relaxation. So they do have some of these types of effects. So some noted effects of the terpenoids include anti-anxiety, anti-inflammatory, antidepressant effects, sedative effects. The myrcene is well known for that. Bronchodilator, opening up your bronchial passages, anticonvulsant, antifungal, antiprotozoal, and sedative properties. So there are some effects of these terpenes. So a lot of times what people are looking for when they want to access cannabis, not as Marinol or dronabinol or some of the just singular synthetics, is they've heard that the whole plant might actually have a greater effect, and that would be considered to be a synergistic effect of either all the cannabinoids or more of the cannabinoids taken together, or the cannabinoids combined with the effects of the terpenoids, which you kind of see like an X marks the sweet spot there. And that's termed the entourage effect. So the entourage of all of the different things in cannabis that are actually having an effect on the body. So some noted entourage effects include when THC and CBD are present in nearly a 1-to-1 ratio, 1 milligram of one for 1 milligram of the other, it actually can reduce some of the anxiety that THC might cause when it's on its own, and reduce some of the memory issues. It may also serve to increase pain control, and in fact, that's what the medication nabiximols or Sativex is based on. It was originally studied and brought into being as a medication in Europe and is now used in 30 countries. Its original application was to deal with the muscle spasms people experience with MS. But it also was recently approved as a medication for managing chronic or unmanageable pain, I should say, in the cancer population, and it's in use in Canada for that. We do not have it here as of yet. The terpenoids, as I mentioned earlier, can also contribute to the effects of cannabinoids. So your caryophyllene has been really researched recently for its impact on reducing pain alongside of the THC or CBD combinations and inflammation. The linalool that we talked about from lavender and the limonene from lemon, these also might help reduce anxiety. And then myrcene is very sedating. Cannabis cultivars that are very high in the terpene myrcene are thought to be so sedating that people associate them with something called couch lock. So when you use that type of product, you're just hanging out on the couch, not moving. And then pinene might actually help reduce memory issues. I see some smiles out there, so some of you have at least heard about that. All right. Let's see. So also talking about what's in a name, I hear a lot from people about, indica does this and sativa does that. Or you hear different strain names like, things that include the words bubblegum or blueberry this or that or the other. And some of those may have developed over time, to kind of indicate the taste or the smell of a particular cultivar. But the new speak that's coming out in terms of the literature and the science is we should be calling these things chemovars, not strains. And what that really refers to is chemical variety. So it's short for chemical variety, chemovar. And there are three primary types. Type 1 would be a THC predominant plant. So the majority of the cannabinoid is THC in that particular plant. Type 2 would have quite a bit more CBD, more of a significant amount, perhaps very close to equivalent. And type 3 would be more of a CBD predominant plant, so much less THC. And then, of course, we can make additional distinctions based on the terpenoid profile of a given cultivar or chemovar. So I wanted you to just see that there are folks out there that are doing terpenoid analysis on these chemovars, so that if you're purchasing a product, you might actually be able to tell what kind of terpenoids are high in that product. So you'd have an idea, if it was very high in myrcene, for example, that would probably just put you to sleep. And if that's not what you're looking for, but you want more of a, pain management with a lift, but not, being completely sedate, you would want to look for something that was low in the myrcene. So this is just to give you a nice pictorial of what it could look like to see a terpenoid analysis profile. So as we get into talking a little bit about the evidence around cannabis and how and whether it might work, what studies we have available to review and help inform us are typically going to be based on synthetic THC products, the dronabinol, the nabilone. A few of the studies will be on extracted THC plus CBD, so these will be the nabiximols type of study. And less often we see studies of whole cannabis. And so a lot of what I'll be able to show you will be more of the synthetic products or the extracts. So I'll start with nausea and vomiting. I basically decided to take a look at some of the main reasons that people ask me about the use of cannabis. I'm talking to patients, for example, about getting around their nausea and vomiting, trying to make sure they're eating enough in the middle of their treatment, or if they're having trouble with appetite. And oftentimes, what ends up happening is they interrupt me and butt in and go, well, what about cannabis? What about that? And so because I was getting that question a lot, I sorry for the aside, but I was getting that question quite a lot from patients that I was meeting with and trying to help them, and it was like, boy, I don't really have an answer for that. So I really need to dig down into this and see what is it that would be helpful for patients to know. Because really they don't know anything and they're asking for any kind of information. So that's kind of why I got into this. But as far as nausea and vomiting, that's one of the primary reasons I have patients ask me about it. And the first set of studies here, or the first several here, are all on some of the synthetic type of products that we talked about in combination a lot of times. And these are review studies, so they might have looked at 15, 20, or 30 studies on various of these cannabinoids. But the first set here kind of talks about these particular things, dronabinol, levonorgestrel, again, which was never released as a medication, or nabilone. Both the nabilone and the dronabinol were released as medications. Looking against kind of traditional anti-nausea medications or placebos. And essentially what was found was that these products were more effective for people, and patients preferred them when they did a crossover to using either the cannabinoid, or then for maybe the next cycle they used the regular antiemetics and went back and said, well, which would you rather do? And the answer was, I like the first thing, which might have been the cannabinoids. Second set of reviews, they looked at the same things, but they found that in separate sets of studies, the dronabinol did decrease nausea and was preferred, but they didn't find any statistically significant effects with the nabilone or the levonorgestrel. And that may be some differences in how some of these studies were conducted. It also might have been that there was more of an effect of the dronabinol or some of these other things when you're just comparing it to a placebo versus comparing it to a traditional anti-nausea medication. And the nabilone, several studies were done on the nabilone against other anti-nausea medications, and 80% of patients found that it reduced nausea, and 78% of people, again, really preferred that product to the traditional anti-nausea drugs. And then finally, the study took a look at dronabinol against a more recent drug that's been more recent than all of these other studies, which is the ondansetron that we're very familiar with now. But at the time it was a little bit newer. And the dronabinol was 71% effective, whereas the ondansetron 64%, and then compared to placebo was only 15%. So could be fairly useful against nausea. It's not something that is usually considered a first-line therapy. That's not the first thing we're going to go to for folks. But for some people who maybe have tried a lot of different anti-nausea medicines and none of them are working very well, that's what I often find is patients come and say, I really want to try something different. Nothing seems to be working, and maybe this will work. So that's often what I hear from folks. So I'm going to move to appetite. This is another reason I often hear people talk about wanting to use cannabis. And in one study with folks with advanced cancers, what was found was that the dronabinol versus a product that we have used for appetite, a prescription product called megestrol acetate, for quite some time, the Meges was just simply more effective than the dronabinol. Only 75% of people had a better appetite, compared with only 49% of the dronabinol. In another study, these were more of an extractive, so it was a THC and a CBD mix versus THC alone versus a placebo, and there was no difference in any of these. And so I want to point out that actually in both of those studies, a fairly low dose was employed, 2.5 milligrams of THC twice daily. And in some studies where THC has been used to improve appetite for, say, HIV patients, it actually was more effective at a little bit higher dose of 5 milligrams twice a day. So could be it's a dosing issue, not quite using the right dose for that particular patient population and situation. So really, really small study. I want to point out that, there's only like 11 to 10 people in this study, but looked at THC to see if it might improve our chemosensory response, so our response in terms of taste and smell. And it did appear that the folks who were given THC had a better response to taste and smell, a significant improvement, 36% versus 15%, and food tasting better. 55% of the THC patients said that food tasted better to them. And then their pre-meal appetite score. So prior to eating, how hungry are you? Basically, the THC folks said, I'm hungrier than the people who had the placebo. But very small study, really needs to be repeated with more bigger numbers so we know if that's really significant. Another big reason that I have patients, wanting to use cannabis or interested in cannabis is for pain management. One of the things I hear quite a lot about is, man, I'm so tired of this constipation with, these pain meds, and this is really almost more distressing to me to be taking oxycodone and so on and so forth and having all this constipation. That's just not very pleasant, not comfortable. And man, what about cannabis? Maybe it doesn't cause as much constipation and I could still get some pain relief. So I do hear a lot of that question. And in the studies where we have mixed cannabinoids, so this might be dronabinol, it might be nabiximols, it might be a little bit of cannabis, but these are again reviews, so it could be anywhere from 10 to 30 studies kind of looked at all together. And some of them were for cancer and other types of pain, so they tended to lump a lot of different types of pain in. And in this case, looking at several studies with different kinds of pain, cannabis did appear to be more effective than a placebo, which would be pretty much a sugar pill. So, but they did feel like there were significant adverse effects, and this was noted to be a lot of the, sort of the psychoactive and mental effects, sort of the memory issues and the lack of coordination, kind of getting dizzy, getting a little bit wobbly on their feet, and they felt like that might not be worth the risk, that group of researchers. Another one looked at neuropathic pain. I know a lot of folks get neuropathy after some of their chemotherapy. And so 15 of 18 trials showed a significant but modest effect on neuropathic and other types of pain. But in that particular group of studies, not any really severe adverse effects. Nobody dropped out of the study for being uncomfortable from the effects of the cannabis. And it did use placebo, but sometimes some of the studies used actual pain medications. And then another study, again, mixed cannabinoids, but cancer and other types of pain, 27 out of 38, what we would call randomized controlled trials. So this is people randomized to the group of study versus placebo or versus regular pain medication, and significant relief in quite a large number of those studies. And then finally, there was one review of just studies of cannabis, and this would have been a smoked cannabis, because it's a little bit older. But for neuropathic pain only, that was the only thing that was really looked at. And 6 randomized controlled trials all had significant relief, but 3 of those randomized controlled trials had what was considered to be clinically meaningful relief. And that means that the effect of the cannabis was more than twice the effect of the placebo. And you can kind of see that in these numbers here, 18 versus 45, 24 versus 53, 26 versus 61. So there may be some modest to significant relief for cancer pain or neuropathic pain using cannabis. So I want to actually look at a different kind of study. So what we're going to talk about next is a type of study where it's prospective, meaning, we enroll people and kind of look going forward, and it's observational. It's really just talking with patients and saying, hey, you're going to start using cannabis. We want to monitor your symptoms and how they're going. And this was done in Israel, where they actually have a pretty robust medical cannabis program. And these folks, when they were recommended for medical cannabis by their medical team, would go and have education by a nursing group who specialized in that. And these folks would say, do you want to be in this study? We just want to monitor how you're doing with this. And they would say, sure, the 131 participants that they had. And they would go through a symptom inventory with them and ask them, how bad are these various symptoms today? And 6 to 8 weeks later, they called them again and asked them how bad their symptoms were at that time. And what's different about this is that instead of these rigid doses, you get only 2.5 milligrams and you only get it twice a day, these folks had access to whole bud cannabis. They were typically smoking that product, and there was no limit on what they could use. So they could titrate the quantity that they used in a day to their tolerance to the side effects and to how well it relieved what they were seeking to relieve. So what you find is that after 6 to 8 weeks, the number of people with no nausea increased by 37% from baseline. And the number of people with moderate nausea decreased by 38%. Boy, those are really close numbers, right? Similarly, vomiting. The number of people with no vomiting up 23%. Number of people with moderate vomiting down 23%. And then similarly, anorexia or having very poor appetite. Number of people with no trouble with appetite increased by 36%. And with moderate, decreased by 38%. And then, of course, with weight loss, they look to see if, with having a combination here of these things, perhaps their weight improved. And again, people with no weight loss during that 6 to 8 week period had the 35% more people with no weight loss during that period as compared to baseline. So a very different kind of look at cannabis and how it might work. And then with pain, same study, the number of people with no pain increased by 23%, but a little differently, the number of people with severe pain actually reduced by 26%. And then moderate pain, it didn't really do much, didn't appear to do much for. And all of this was statistically significant for a trend in the numbers. So another thing I hear a lot from patients is they come in and they say, hey, I heard that cannabis might be able to cure my cancer. And they've, heard various things on the internet or read this or that or the other. They've heard about this Rick Simpson story. And what I want to point out, and I don't want to spend a lot of time on it, is that the evidence we actually have in terms of the research, not anecdotal stories like my brother and my neighbor's neighbor and my friend's friend, but the actual research that has been done mostly has been done either in animals or in cellular studies. So that's not really yet translatable to us. We had one small human study that really just looked at putting THC into the area of the brain where brain tumors had been removed. And it was mostly just looking to see, was it safe? Did people have any adverse effects as they increased the amount of THC that was put into the brain? But they weren't really looking at whether it helped, because it was what's called a phase 1 type of study. It was very small, only 7 to 9 people. You can't really do a lot of statistics on super small studies like that. And a couple people happened to outlive, their projected, but again, that could have been a coincidence. It doesn't necessarily mean that it was the cannabis that did that. But a lot of this type of information is why people they hear that, or perhaps it gets blown out of proportion and they come in and they're hoping to just use cannabis. And I have to say that it's not time to be just thinking that cannabis is the only treatment that you want to use. Possible, maybe, and there's lots more research that needs to be done and that could be done to look at that, but absolutely not a certainty at this time. So the next thing I want to talk to you a little bit about is different administration routes and give you a little bit of information on that, because I find that a lot of folks that I talk with who maybe have never used cannabis before are not aware of how they might feel, how long it might take for something to get into their system and for them to feel effects, and then how long it might last. And that actually varies depending on the route that the cannabis enters your body. So inhalation, which includes smoking or vaporizing of cannabis, the onset for this is quite quick. It's 5 to 10 minutes. And the duration is actually fairly short compared to some other routes, 2 to 4 hours. Bioavailability means how available is the medicine using it this way, and it really varies among people. You know, you could get about 10% of the medicine in, you could get up to 35%. So that can make it a little challenging to figure out how much you should use. It is thought that vaping has less toxic byproduct than actually smoking of cannabis. And I think Liz is going to talk a little bit more, explain a little bit more about that. I think there's some cautions, some things to kind of be considerate of when it comes to thinking about an inhaled type of product. There are products out there called dabs. What they are, they have several names, but that's a common one. And they're volatile, concentrated sources of cannabis, primarily usually THC. And they're extracted via solvents, liquid gas, like propane, for example, or carbon dioxide. Safety concerns here have been that in a study conducted in 2015, they found residual of these different solvents, like butane and hexane and things like that, in over 80% of products that were tested at that time. And 33% of samples had pesticides, including one that is not labeled for use on food crops. So I would assume that if the EPA is not telling us we can use it on foods, we probably wouldn't want to put it on anything else that might go into our body. Not that we know for sure that these things would harm you, but you know, they are concentrates, so anything that's getting into the plant could therefore become very concentrated when it's getting into a concentrate. Another thing is that the literature talks about these things because of the very, very high dose of THC, and some people aren't aware of that when they go to purchase product, that it's so concentrated you're getting quite a lot of the medicine. And if you're not aware of that, then you may have really significant side effects that could make you very uncomfortable. So for that reason, it might not be very appropriate to use as medicine, just because it's so concentrated. Another caution with inhaled product is that there is possibly a risk to someone who's severely immunocompromised. Green bud, whole green bud, can grow bacteria and molds, as we know in our own homes. You know, plants need moisture and they need, you know, all that kind of stuff. And I know my house plants get mold right inside of the soil there sometimes if they're too wet. So same thing can happen with cannabis. You know, these things, bacteria and molds can grow on there. And aspergillus is a mold type of product, and there have been a few case reports of people getting aspergillus via inhaled cannabis products. And aspergillus infection for some people could be fatal. So not to be scary, but just to say, hey, it's kind of a good idea to know, are your products tested for these types of things? I know that in Washington, with the continuing evolution of our medical and recreational product laws, they are testing for bacteria and molds, and they have certain tolerances for those things. And in the state of California, I'm going to let Liz tell you a little bit more about that because she lives here and knows. But I have found too a study in Israel. Again, those guys have a pretty robust medical cannabis program, and they have done testing, and they've actually tested whether or not they could sterilize cannabis product and get rid of any bacterial or mold contaminants. And if that product would still then have roughly the same amount of THC as it originally had, because you can destroy it with high heat, which is usually how you would sterilize something. So at least in Israel, they found out that there are some sterilization methods that could get rid of bacteria and mold, so that's kind of encouraging, but I don't know if we're quite to the point of using those things here in the US yet. But stay tuned. So oral ingestion is usually via edible type products like, candies and brownies and cookies and candy chocolate bars, stuff like that, or capsules. Sometimes, oil capsules will contain THC, and you swallow those, and they get absorbed inside of your gut in the stomach area. And the onset of that is quite variable, from 1 to 3 hours. So that's not really a quick medicine, if you think about it. And then duration is quite long, at 6 to 8 hours. And bioavailability, again, is really variable. So if a friend of yours hands you a brownie and says, I took this much of the brownie and I was good, it was all good, I didn't have adverse effects, that might not be indicative of you, because that person could absorb very low quantity, say in the 4% range, and you might be a person who absorbs things a lot more efficiently and be able to get 20% out of that. So all of these things can make it kind of tough to titrate the dose or figure out the right dose for you. In addition, when THC is absorbed in the gut, the first place the blood flow goes is to the liver. The liver does some metabolizing of that item. And one of the things it makes is something called 11-hydroxy-THC, which is the abbreviation for. And this particular metabolite is a very potent psychoactive, giving people those psychoactive effects that some people are not really wanting or find very unpleasant. That's because that particular metabolite can get into the blood, go from the blood to the brain really easily, more easily even than THC. So this type of metabolism from this oral ingestion can reduce the bioavailability of the THC, meaning you're not getting as much of the medicine that you want, and give you more of the high. So I tend to think of edible, particularly things like brownies and candies and things like that, as maybe a little bit more of a recreationally oriented product. And again, all of these things contribute to difficulty determining a dose that's comfortable and effective. Just to mention that several years ago in 2015, a group of folks decided to take a look at edible products, particularly more of the food-based products, and determine if the label that they said, what they said was on the label in terms of THC content, for example, was accurate. And they found that only 17% of products were accurately labeled. And a lot of the products were underlabeled, meaning they had a lot greater THC content than the label would indicate. And some things were also just overlabeled, had less THC than it really said it did. And again, this can contribute to difficulty dosing, figuring out how much is the right amount for you. You think you're getting 1 milligram, 2 milligrams, maybe you're getting 3, maybe you're getting a half when you try something. But the other thing to think about is if you were picking up edible product and the first 5 times you pick up an edible product, it happens to be an underlabeled product, the next time you get it, it's overlabeled, then you figured out how much to take of this underlabeled product, and then you end up taking a whole lot more because the next piece you got had a lot more THC than the label said. So again, that contributes to a tough time figuring out dose. I think that more recently, I know in Washington, they've gotten really good at making sure that people are doing more accurate testing, and again, Liz can probably speak to what's going on here with that. So oromucosal, that is actually the inside of your mouth. It's the tissues inside of your mouth, your cheeks, and your gums. And that type of delivery tends to be things like sprays or tinctures, which are droplets that you could put in your mouth. And the onset here is not as quick as inhaling, but quicker than the edibles, 15 to 45 minutes on average. Duration's still pretty long. And then the availability of the medicine doing it this way is still highly variable, can be increased when you've had a recent meal, for example, and is somewhere in between the inhaled product as far as how much you can take in versus oral product. But there is less of that first pass metabolism with this type of medicine administration, and so that might be desirable because you don't get quite as much of that psychoactive and that high and some of that discomfort, that uncomfortable feeling. Some people like that feeling and some people don't, so I'm just putting it out there for those of you who might not care for it. And there are the possibility of using suppositories. I have heard that availability of this type of product is kind of spotty. It just depends on who's carrying it, but I also know that there's instructions on the web on how to make your own, so you might be interested in that. But my understanding is it's favored because it's pretty well absorbed, and there isn't as much first pass metabolism, so again, you don't get quite as much of that very potent psychoactive metabolite. Peak concentration can occur anywhere from 1 to 8 hours, so that's a little bit variable. But bioavailability, taking in the medicine this way is pretty good compared to oral product. And then finally, there's dermal applications, so this is putting stuff on the skin. Creams, ointments, there's very few studies. Mostly what you're getting is a local effect. For the most part, rubbing a cream into your skin, you're not going to tend to get that medicine into the bloodstream. It's a little different potentially with the transdermal patch. I know there are some patch medications for pain and for nausea that people have used or heard of. And only in preclinical research, which would be an animal model, have they found that they may be able to maintain sort of a steady level in the blood or the plasma for about 48 hours with a dermal type of patch. But I don't know how many of those are really out on the market, on the cannabis market. I haven't heard very much about them. So this may be preliminary research and a product that would come out much later after more research. So moving on to sort of the why we shouldn't, when should we maybe not use cannabis, or what kind of cautions should we be aware of? Contraindications or reasons to really not use it include if you happen to be allergic to anything, to the cannabis itself, which you might only know if you try it, or the vehicle for it, whatever vehicle it's in. Obviously, if you're deathly allergic to chocolate, you probably shouldn't have a cannabis brownie. Pregnancy and breastfeeding remain contraindications to using cannabis. I've had a lot of people contact me and say, well, what if, I have a lot of vomiting and nausea because of my pregnancy, and it still does cross through the placenta and also into the breast milk. So at this time, it's not recommended for use during that time. If you have heart problems, if you have major heart or respiratory problems, you might consider not using it as well, or at least discuss it with your doctors closely before you do. And because most substances we take in are in some way metabolized by our liver or our renal systems, then if you have major renal and liver failure, it also might not be a very good idea to use cannabis. And then finally, there's a little bit of a chicken or the egg argument whether cannabis might promote schizophrenia in particular, or whether it just happens that folks with schizoaffective disorders choose to use more substances. But since the jury is out on that kind of thing and we don't know about cause and effect, if you have schizophrenia or have a family history, it may not be a good idea to use cannabis. Also, if you suffer from bipolar disorder or severe depression, it's possible that cannabis could worsen those types of conditions. So you'd really need to have big discussions if you're insisting on wanting to try it in those situations. Caution, we should use cannabis with caution with any ancient history, so to speak, of heart or cardiac pain. High blood pressure, cannabis can actually lower the blood pressure in some situations, and so if you're already on blood pressure lowering medications and then this lowers your blood pressure more, that could be problematic, or it could be hard to regulate blood pressure if you're using cannabis while you're on those types of medications. And then, of course, if you have asthma or obstructive pulmonary lung disease, inhaled cannabis may not be very comfortable or safe or good for you to use. So adverse effects, this is just to give you, kind of a laundry list of things that you might experience that are usually not effects we're looking for. But drowsiness, fatigue, dizziness, anxiety, nausea. The cognitive effects, things like confusion, being disoriented, perhaps having hallucinations, impaired memory, are really common, and most people are aware of those. And of course, with smoking, you can get coughing, excess phlegm production, bronchitis, that type of thing. Those are the most common. Euphoria, blurred vision, headache are also fairly common. Now, some people might say, is euphoria really an adverse effect? Because maybe we kind of like the way that feels. And I've actually heard palliative care physicians say, hey, that may not be such a bad thing for people who are really struggling with their symptoms. So, and then more rare would be the low blood pressure, the psychosis or paranoia, really rapid heart rate, hyperemesis, which is also excessive vomiting is actually what that is, and then diarrhea or loss of coordination. So those are much more rare, particularly when people are using cannabis as a medicine and usually trying to use just the least amount that would help with the symptom they're trying to alleviate. So there are some cannabis drug interactions. The effects of anything sedating, such as alcohol, opiates, and benzodiazepines, like the Ativan, Valium, Xanax, those types of things, are going to be increased by THC. And so it's really worthwhile to know. I had a patient come in once who was using medicine for pain, decided to use Rick Simpson oil because, he was thinking more that it might help cure him. He was still getting his treatment, but and I think he might have used some Ativan coming in, for the anticipatory nausea, so they had told him to go ahead and use Ativan before coming to the clinic because he really got anxious about coming in. And he came in, and within 15 or 20 minutes, he was very, very somnolent. We had to send him down to the ER. And so, he had to kind of be taught that, hey, all these things have an additive effect and make you super sedate, and you scared us, so please don't do that again. But he just didn't know, so it is important that you know that and be aware. And then CBD, this would be more applicable to people using it for seizure disorders, which most cancer patients are not doing, but there is something, clobazepam is a type of benzodiazepine, and when CBD was studied for the anti-seizure effects in the pediatric patients, it did seem to increase the sedative effect of that particular medication. So it's just worthwhile to note that, because really high doses of CBD could potentially do that with other like medications. So a little bit about dosing. One thing I think is important to understand about your physicians is that by federal law, they have a First Amendment right to be able to talk with patients about cannabis and especially just provide information, but they can't do an actual prescription, which includes dose, route, and frequency. So, they can't do all three of those things, or they're actually, particularly in written form, or they're giving you a prescription, and that's something that federal law doesn't allow them to do. But we can give you information and help you to make an informed choice. So that's what I'm hoping you'll get from a lot of this evening. And based on the literature, the start low, go slow, and stay low adage should help limit the adverse effects. If you're getting the least dose that you can find to alleviate the symptom, you don't necessarily need to go higher. More is not necessarily better. And this aids tolerance to the cannabis as medicine. Really commonly, according, again, to literature and research, folks are typically tending or trending towards using high CBD and low THC products. A lot of folks don't want to get too much of the THC. They already are kind of nervous about those psychoactive effects. And CBD does not have psychoactive effects. So for some people, that might feel a lot safer to give a try for something like neuropathic pain or nausea or even anxiety. One should always titrate or increase the dose based on their side effects tolerance. If you get to a point where your side effects are really uncomfortable, then you need to back off. And if you're finding the side effects are so uncomfortable that you can't get the medicine to a level that helps you alleviate symptoms, it may not be the right medicine for you. Most folks may use more of an oral product for chronic problems, say chronic pain, partly because if they can figure out the right dose and how frequently to take it, given it does take quite a while to start working, it does last for quite a while, and it can be nice to have something that you don't have to take super frequently for it to work. But for very acute or breakthrough type of issues, people may also find vaporization of product useful. And again, Liz is going to give us a little more information on those routes of administration. And then a study of folks who were using cannabis over a year's time for chronic pain found that they typically use somewhere between 1 and 3 grams of herbal product per day, and that was product that had an average THC content of 12.5%. So that starting quantity there was only 12.5 milligrams across the whole day. And that was for chronic pain, not necessarily for nausea, which you probably wouldn't use THC or any cannabis product for nausea every single day. You would use it sporadically. But I say that just to say that across that year, people didn't have to increase their dose. There was not a tolerance that was built up. They figured out a dose that worked. They stayed with it. It continued to work. They didn't have to keep increasing the dose to continue to get relief. And then finally, I hope this would go without saying, that you really shouldn't drive if you're going to use THC product that would be giving you psychoactive effects. Hide the dope, Frank. He's on to us. We were driving way too well compared to normal, right? So just know that you can, again, Liz will mention this too, but you can get driving under the influence if you're using THC and you're found to be driving erratically or in any way that's unsafe. So plan to stay home or have someone else do the driving if you do need to use a THC type product for your medicine. So in summary, cannabis has a very long history of medical use, but a much shorter history of research, and we need quite a bit more of it to really inform us better. but we know a little bit, and that it may be effective for some conditions, but there are also adverse effects and pros of using it. These include, for example, the mode of use. There's a difference in the effects that we might experience. There's possible contaminants unless we have product that's well tested and we have that testing data available to us from the dispensaries, and variability of content, and also just individual variability in how one person might actually absorb medicine versus another person. And of course, our individual medical history plays a huge role. So this is really a complex topic. It's not very easy to just figure it out after hearing a 40-minute talk, but it kind of does require a little bit of research on your part and learning about these types of things and making, hopefully, an informed decision. And then the best dose, again, is the lowest one that you can use for relief of your symptom with good tolerance of the side effects. So finally, just a few resources. The International Association for Cannabis Medicine has a great database of studies. You can actually search. They have a little search engine that already has some things you can select. It's totally different than Google. You can select cancer, and you can select nausea and vomiting, and you can select the years if you want current studies, that type of thing. Americans for Safe Access has quite a bit of great information, including making sure that you're complying with local laws, or at least where to find that information. Cannabis Pharmacy is an excellent book by Michael Backus that's really written for the layperson. It's not a lot of science speak. You can pick it up and find a topic in there that you're interested in, like mode of administration, and they'll have a whole chapter on it. And lots of really good information, and endorsed by a couple of physicians I know that do palliative work, and one who has done 20 plus years of research in cannabis, Dr. Ethan Russo. And Chronic Relief is another book that was also endorsed by Dr. Ethan Russo, by Nishi Whiteley. And I have the Cannabis Pharmacy book and have really enjoyed it and sharing it with people. I have not necessarily looked at Chronic Relief, but if Dr. Russo endorses it, it's probably a pretty good read. All right. So with that, I'll have Greg introduce Liz. Thank you.
Thank you, Kelay. Why don't we open the floor up for a couple of questions? Sarah will walk around with a microphone, and if you would, speak into the microphone.
It seemed like it was consistent that there were really very few studies. Is there any the floodgates opening up about studies and, pilot research?
What I can tell you is that if you go to PubMed, which is a repository for medical literature, and you put in cannabis, you will get thousands and thousands of hits. Part of those will, though, be around things like using, the abuse of it and so on and so forth. So kind of trying to sift through that can be really challenging. The problem that we have in the U.S. is that as a Schedule I drug, the only thing that they allow it to be studied for is as a drug of abuse, not a drug of use. And so the research that is coming out is usually from other countries. We see robust information from Israel quite frequently. So I can't say that we're about to see a torrent of things, but if we ever could get it at least to be a Schedule II, then I suspect people would pick up and start looking at it more closely.
I'm a little confused about the cannabis, the CBD part of it. I've heard that the cannabis plant has two parts or two flavors, and there's a hemp plant.
Mm-hmm.
And if you have a salve or a whatever from the hemp plant, then there's no danger of any THC in it. But do you still get a good CBD product?
So there's a sort of a two-part question you're asking there. And so in years past, when you might have recalled me mentioning that we talk cannabis sativa or cannabis indica, and we've called those two separate plants or strains of plants. One of those was thought to be more the drug strain, the other the hemp strain. So hemp is a different name for one of those two distinctive plants. And hemp typically is more of a CBD plant with extremely low THC in it. So in that sense, it's a language thing. And yes, there's still a lot of products that will say this is just hemp oil. It's not, it's not THC laden. It's not going to have the psychoactive effect. On the other flip side of that, whether or not it's very effective may depend on, how much CBD content is in there, and if the vehicle that it's in is something that can permeate your skin well. And, again, with the dermal application I mentioned, any type of skin application, there's just not a lot of research on whether or how well those work. So if they work at all in terms of a cream or an ointment, it's going to be more of a local effect. So you're not going to rub it on here and feel less pain on the other side of your body, right? And you may not feel less pain for deep pain either. It could be that if you have surface pain, that it's going to permeate just that part of the surface. But again, we need a lot more research on particularly the skin applications of it.
I have one more question before Liz.
I took copious notes, but I can't remember. You talked about one version being kind of making people into couch potatoes.
So that was related to the terpenoids. So again, there's cannabinoids and there's terpenoids, and the terpenoids are things that can have that effect on the body. Myrcene was the one. Myrcene was a terpenoid that is a very has sedating properties.
So of the three types, is myrcene in one of the three types?
So no. So I think what you're asking, 3 types were the 3 chemovars of cannabis, and that's the cannabinoids.
Okay.
So with the 3 chemovars, you're looking at either THC is predominant
Right.
in the plant,
Right.
or there's one with fairly equal or almost equal amounts of THC and CBD. Those are cannabinoids. Type 3 was a CBD, which would be more like the hemp that she was talking about. Terpenoids could be in different quantities in any of those types.
Added into it then.
Yeah, they're a completely separate class.
Okay.
And we don't include them in the, one concept of the chemobar is that primarily it's how much THC and how much CBD is in that chemovar.
Right.
But another component of that chemovar is what is the terpenoid profile.
Exactly. So what I'm getting at is, what would you recommend for someone who's having trouble with insomnia?
It could be that whether it's a type 1, 2, or 3, if it's high in myrcene, regardless of what type, it could be something that helps you to sleep. I've had a lot of, this is more anecdotal, but I have had patients tell me that CBD products that happen to have, more myrcene seem to help them with sleep. But again, do we have a lot of research on that? I didn't talk much about sleep. There's probably some research around that, but I kind of stuck more to the main things that I see people asking about nutrition-wise.
Well, I'll offer myself for research if they ever.
Well, you should look for clinical trials as soon as we get it descheduled.
Thank you.
You bet.
Great, thank you. Kelay and Liz are going to be available for questions, and both formally and informally after Liz speaks. As a way of introduction for Liz, Liz has been assisting cannabis businesses owners as well as educating the public about the use of cannabis for the last 15 years. She's been a liaison between government, community, and cannabis businesses, as well as helping to create local cannabis regulations. She approaches the subject from a botany and biology experience. Doctors and patients consult with Liz on a regular basis, customizing cannabis treatments and programs. Please welcome Liz Rogan.
Good evening, everyone. Thank you so much for your attendance tonight. This evening, I'm going to go over the large variety of products that are available, the methods of ingestion, licensing, and safety issues. There are many different choices when it comes to choosing between all of the products and different methods of ingestion, from edibles to suppositories. With edibles, there is a large array of products for you to choose from chocolates, baked goods, gummies, drinks, and there's even barbecue sauce. When using edibles, it is very, very important, as Kelay noted, to go low and slow. So you want a very low milligram dosage, and you want to increase the milligrams that are ingested very slowly to achieve the desired results. Edibles do have very long-lasting effects because of the way they are processed in the body. So finding the correct dosage for this method of ingestion is key. When smoking cannabis flowers, the product must always be lit with a flame. The product is typically ground up. In a joint, it is wrapped up in a paper or a tobacco leaf. A bong or a water pipe uses the water as a filtration method. A pipe or a bowl has ground up cannabis placed in the bowl-like section, and it is lit and inhaled. A dugout is very similar to a pipe, but it looks like a cigarette, and it has a very small hole at the tip for cannabis. Vaporizing. Vaporizing is the process of oil being converted to vapor. The main advantage of vaporizing is that it does not cause smoke. Older models, like the one you can see here, do not often provide accurate information on temperature. So using newer models is suggested because the technology is much better at monitoring the temperature and the dosage amount. Oil vaporizer pens. These are very popular. You've probably seen people with them all over. So essentially it is using an oil pen, or vaping, as it's commonly called. It utilizes cannabis oil that is concentrated. It's typically over 50 to 60% THC. And these do come in a variety of cannabis strains, sizes, and batteries. There are many options, as you can see up here. There are often additives for different effects, to change the viscosity, to change the color of the oil. This is a very discrete form of ingestion, but more research does need to be done to assess the long-term safety. Dabbing concentrates. This here is a very concentrated cannabis oil that has all of the other plant materials, lipids, and the fatty acids taken out. Because of this, it is extremely thick, very potent. It is frequently called wax, butter, crumble, shatter, or dabs. It requires an extremely high temperature to vaporize the oil. It is also extremely potent, often over 90% THC. So using with extreme caution is suggested, and it is not recommended for novice users. Tinctures and capsules. So tinctures and capsules both utilize the oral method of ingestion. They are excellent for reliable, accurate dosing. Tinctures typically come in the form of sprays and droppers. They are typically a cannabis oil that is mixed with a variety of bases, either coconut oil or other oils, glycerin, or alcohol. It's usually based on your personal preference. Capsules often have very simple ingredients in them, such as cannabis oil and coconut oil. The topical application of cannabis is possible with a large variety of products, including bath bombs, salves, massage oils, and scrubs. Many people do report them to be very effective and with limited or no psychoactive effects. Juicing cannabis is also another method of ingestion with limited psychoactive effects. One very important thing to remember when using these leaves is that they are hopefully organic or at least free of pesticides and herbicides. Transdermal and suppositories are both methods of direct ingestion into the body, but more research is required to understand the efficacy of these methods. So now that we've looked at the available products, how do I proceed? The first step should be consulting with your healthcare provider. Your healthcare provider knows your medical history, the medications you take, and they can help you decide what might work best for you. You may need a medical recommendation to obtain cannabis based on where you go to get it. Your doctor can write you a medical recommendation, and this is important to note, it is not a prescription, and this is required to enter a medical dispensary. To be eligible for a recommendation, you must be 18 or older, a California resident, and have either a driver's license or a state ID. The recommendation is typically valid for 3 months to a year, and it must be renewed to continue to purchase products from the dispensary. The dispensary will verify your recommendation with the doctor before you're allowed to enter and make purchases. This is an example of a form for a medical recommendation that your doctor could use. And you have several options when it comes to obtaining cannabis in Santa Barbara. A medical or adult use dispensary will allow you to go in and see the products in person, and talk to people before you make a purchase. The staff are typically called bud tenders. These people may have good information for you. It is important to find someone that you trust. Currently, medical dispensaries are the only option in Santa Barbara. In the next few months, adult use dispensaries will be opening. All of these dispensaries go through a very strict licensing process, and they are the only place to buy California state compliant lab tested cannabis. You can use this website to verify the license of the retailer. Another option for obtaining medical cannabis is delivery. You can look online at the menus to look at the variety of products. Ordering is typically over the phone or online. You can talk with the staff over the phone and ask questions, but you will not be able to see the products in person until they are delivered to your door. And there may be a delivery fee or a minimum order with this method. Delivery services may be licensed in another area and delivered to Santa Barbara. It is important to check to see if the retailer is licensed, as these people can deliver statewide. Currently in Santa Barbara, we do not have any licensed delivery services. A medical collective is a group of patients who grow for their members. Under the Adult Use of Marijuana Act, the medical collective model expired on January 9th, 2019. And so now all cannabis businesses must obtain state or local licenses, whether you're medical or adult use. Local retailers. Currently, there are 3 permits awarded for medical dispensaries in Santa Barbara, and there are 2 open. For adult use storefronts, the city has allocated 3 permits. Currently, none are open. They're hoping to open within the next few months. With delivery services, there is 1 adult use permit awarded to date that is currently not in operation, but will be very soon. In Goleta, there are 3 medical dispensaries that are open. There are allocated up to 15 permits for adult use storefronts. Currently, they are still in the licensing process, and no one has obtained these permits yet, and there are currently no licensed delivery services in Goleta. One thing to note in Santa Barbara is if you're going to go to a medical dispensary, there is an ordinance where you need to register 24 hours ahead of the time you will enter the dispensary. That is only in Santa Barbara City. In the county of Santa Barbara, they have permitted up to 8 dispensaries or adult use storefronts, but currently none of those licenses are taken and there are no delivery services in that area. Okay, so I wanted to talk to you about the supply chain. What's really important to note about this is there's over 14 main license types, and licensed cannabis businesses can only do business with other licensed cannabis businesses. So if you look at this supply chain, every single product must go through a testing lab before it arrives at the retailer and ultimately the consumer. There is a track and trace system in place that tracks the plant from seed to sale. So from cultivation through this whole process, each plant is labeled, has an individual number, and is followed through. It's important to note that these testing standards are very rigorous, and every single product must go through this. How do you know if a product is safe? So if you shop at a licensed retailer, you can be assured that your product is state compliant and meets very strict standards. You should look for this California approved cannabis label. All products must also have lab testing on them. And as you can see, the lab testing is very rigorous. We are now in a phase 3, which is the most intensive lab testing levels that they have they test to parts per billion. So it's very important to know what's in this, and this will also help you make informed decisions. So currently it is still federally illegal. In November 2017, with the Adult Use of Marijuana Act, they voted adult use into law. That regulates both the medical and recreational side of buying, selling, giving, where you can use it, growing, processing, etc. It is very important to note that local regulations do supersede the state regulations. So the local jurisdiction has the authority to ban or allow it. Regulatory changes are ensuring now that all the licensed products are going to be properly tested and labeled, so you can walk in as an educated consumer to make better choices. It is very important to consult with your healthcare provider before you make any changes. As Kelay has said, there are many things to take into account, and your healthcare provider may need to reach out to other people. You can also utilize these websites that we've offered here. So cannabis may have potential to treat some symptoms of illnesses, but overall more research is needed, as you can see. So I always urge you to educate yourself and be an informed consumer. And so,
Thank you, Liz. Let's do a couple of things. One, thank you very much. I think we all found that to be very educational. I'm going to bring a couple of chairs out, have them sit down, and we can entertain questions. And Sarah, if you would, maybe we can bring the microphone around. There's a question in the back.
Hello, I just actually purchased some cannabis today online, and they didn't ask for any paperwork at all. And it was supposed to be a very reputable company, but I'm just wondering if it's possible you could recommend, well, first of all, if you could say how many of these companies are there out there, let's say the top tier companies, and what would, and can you recommend any companies by name?
Well, first off, that is very concerning that you would buy cannabis online without any documentation required. I can tell you that is not fall in line with any state regulations, and so that is not compliant currently. Unfortunately, I cannot recommend any. I can't recommend any companies for you to use, but I do suggest you look at our websites and make educated decisions based on that.
Is the county rules the same as the city?
No, they are not the same at all. For personal use in the city of Santa Barbara, everyone's allowed to cultivate 6 plants, but you can only grow 1 plant outside if you live in the city. The other 5 can be inside. If you live in the county, you're not allowed to grow any plants outside. You have to grow your plants inside. The same thing in Goleta. And as I showed you, I think on the slides, the dispensaries, like the city of Santa Barbara decides how many they're going to allocate, and where they're going to be, what zoning. Same thing with each different entity. And they don't all sit together and talk, and so often it's trying to figure out the differences between the jurisdictions.
So what you can recommend is don't buy gray or black market, but California labeled, certified.
Yes, yes, that is the only way currently that you can know that your cannabis is lab tested.
Hi, I'm questioning about the vaping, and I'm wondering if if you get it from the dispensary and, it's been tested and doesn't have anything bad in it, how does it affect your lungs? I mean, is it okay for your lungs then if it's been tested without, doesn't have any solvents or anything, or has there been some problem with it? Like, I know the smoking it, there may be more issues, but I'm wondering if vaping is safe in that way.
Is vaping safe? I would say that first off, definitely more research needs to be done to look at the long-term effects on your lungs and the body. Anything you would buy from a dispensary that's licensed is going to go through that very rigorous testing process. They'll make sure that there's no solvents, no mold, no pesticides, because when you're getting that oil, it's like very concentrated down from the plant. So there might be something in the plant as a small amount, but sometimes when it gets very concentrated, it can be a larger amount. As in terms of the effects on your lungs, you are not lighting something, so it's not combustion. But I'm going to pass this off to Kelay and see if she has any better answers.
Thank you. It's my understanding that when you're vaping versus smoking, the temperature, first of all, is much, much lower. It can be 150 to 160 degrees versus upwards of 400 to 500 degrees with flame. So you're not creating, number one, as much heat. You're not creating as much what's called polyaromatic hydrocarbons, which is something that can be from organic material when you heat it at very high temperatures. It's not nil. There's not none of it in a vaporized product, but there may be far less of it. So like she said, we need more research in terms of long term, but the likelihood of it being less dangerous than smoke certainly exists, but it's really hard to say. I do think that some people with really sensitive lungs may not tolerate vaporized product either, because it's still something that's going into the lungs. It's not a normal thing that the lung is looking for, just out of common sense. But we don't know as much as we need to know about that.
Hi, I had a question regarding from the business side of things. So you have an entity in town that's been through the vetting process, has received their license, is now licensed in the city of Santa Barbara and the county of Santa Barbara. What protects them from federal liability?
Well, technically, they could be prosecuted federally, but the state of California has said that they're going to, is basically trying to protect that as it's part of their entity. And then I know during the Obama era, they had made a decision saying they weren't going to be going after anyone with like states that had cannabis programs. They weren't going to be directly going after them. I think the new attorney general also said that. Yeah. But honestly, I mean, you're always at a risk for federal prosecution. So.
I would think the state would want to protect their tax revenue that they're receiving from those entities too. So that's.
I know that banking is something they're trying to work on, and I think once that gets settled, that it may be easier. But regardless of that, it is still federally legal as a Schedule I drug. This guy has been
waiting here. Two-part question. One, and this is to you. Do Sampson Clinic doctors recommend cannabis for patients who don't request it? And the follow-up is, I didn't hear you say in any of your comments that cannabis would be your first choice or even your preferred choice for any kind of medical condition. Can you answer those two questions?
Can you please repeat the first one?
Yeah, the first one was, do Sampson Clinic doctors recommend cannabis for patients who don't request it?
That I don't actually know, as I don't work with those physicians.
What'd you say?
Right.
Yeah, maybe,
Really quickly.
maybe you could answer that.
I don't think there are many Sansom Clinic doctors that will prescribe unless requested. So no, I don't think it's ever going to be the first line therapy for any doctor.
And then the second question is for you, I didn't hear you say that cannabis would be your personal first choice of treatment for any of the medical conditions you listed.
Right. And much of the literature also supports that. So I try to base anything that I recommend on what the literature is saying. And even, folks who write prolifically on the use of it as medicine, for instance, Dr. Ethan Russo, who I mentioned a couple of times, often say, it's not necessarily a first choice for a lot of reasons, including the fact that regulated drugs, are typically have been for much longer regulated in terms of purity and quality. And even what she describes, and even in Washington State, regulation of purity and quality of cannabis is quite new. So, you may ultimately be safer with regular prescription medications in the sense of, do they have any of these contaminants? But typically it's not something that anybody's going to recommend as a first line, because you also have the issue of it, being federally illegal and the concerns around, the potential problems that people could experience. So I wouldn't say that it's a first line recommendation across the board in terms of physicians I see practicing and what I see in the literature. It's not typically considered a first line recommendation.
Liz and Kelay have agreed to stay for a while. If you have any questions that you would like to ask them personally, please feel free to come up. And as a final note, thank you very much for partaking in our inaugural event. I think it went very well.